Good evening to each and everyone over here. I am thrilled to welcome you all for today's informative webinar on management of hepatic encephalopathy in emergency. I am Vijay, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the day, Dr. Ayush. Dr. Ayush is a consultant physician, diabetologist, and a pulmonologist based in Bhopal, currently working at CMCH and Manas Sarovar Diligent Care Hospitals. He leads the palliative care unit at CMCH and is trained in palliative medicine from the Institute of Palliative Medicine India. A passionate digital health educator, he has created 500 plus medical videos and built a YouTube community of over 1.5 lakhs followers. Dr. Ayush is pursuing the executive program in healthcare management at IIM Shillong and collaborates globally as faculty with the University of Buckingham from UK and as a medical consultant with healthcare firms in the US and India. Over to you, Dr. Ayush.
Thank you, Vijay, for the very warm welcome. And it is always a pleasure conducting CME on the platform Mediversal. And I welcome you all. And the topic, as by the name suggests, will be discussing hepatic encephalopathy. So, an open question to the audience: can any one of you define hepatic encephalopathy in simpler terms? Even any one of you, the keywords would help. Not a very elaborated definition, but again, keywords. What exactly, if you understand by the term hepatic encephalopathy, or you have come across hepatic encephalopathy, any patient or so? Any idea the keywords, what exactly it is? Before we go ahead, quickly, anyone from the audience, whether you're right or wrong, because understanding hepatic encephalopathy, high bilirubin affecting brain. Okay, we have one answer from Parmeshwari. Neurological symptoms due to liver dysfunction. Bang on right, Dr. Yashodan. Neurological symptoms due to liver dysfunction. And what exactly is the culprit? If we talk about the what levels increase or decrease in hepatic encephalopathy? Ammonia. Yes, ammonia is the main culprit. Potassium is also there, but again, ammonia is the main and so culprit. So what exactly happens? Altered sensorium due to raised ammonia. Bang on right. Yes, Balaji. So every one of you are right. This is the basically hepatic encephalopathy. If we talk about, so it is a reversible neuropsychiatric syndrome. So neuropsychiatric syndrome, why it happens? Due to liver dysfunction, maybe due to portosystemic shunting, due to the accumulations of neurotoxins. And what exactly are the neurotoxins which you named? That is the ammonia. And so this impairs the brain function. We'll be seeing what exactly is the pathophysiology when we're talking about. So it is a liver's inability to eliminate toxins from the blood. So that's why there is buildup of toxins in the blood and significantly damage to the brain. Now, coming to the brief history of it, if we talk about, so Hippocrates, the famous scientist or the researcher going back to the 460, 371 BC, described the association between jaundice and acute behavioral disturbances. So you see, back to so many years, maybe 100,000 years, the scientists were so advanced even at that time. So they have described the association. G.B. Morgagni reported that, there was who was an alcohol misuser in the past. So this man developed ascites and some episodes of agitation, and then he developed prolonged episodes of somnolence, delirium, and finally died. So his autopsy revealed the existence of liver cirrhosis going back to the 1682, 400, 500 year backs, and Morgagni, Lanac cirrhosis was being named from him. Han et al. Showed the dogs undergoing experimental portocaval shunt developed behavioral changes within 10 to 14 days after surgery and was called as a meat intoxication syndrome. So over a period of time, even in the early 90s, Van Colt reported the capacity of ammonia to induce coma and stupor in patients with cirrhosis. And Sherlock defined hepatic encephalopathy, coined portal systemic, but the new term, that is the hepatic encephalopathy, was being coined in the year 1957 by the Fazekas et al. Rickers' first identification of latent HE and Somnorus, again hamster, coined the hepatic encephalopathy. So when talking about the definition, which you already have told, it is a brain dysfunction due to liver insufficiency and or portosystemic shunting. It manifests as widespread of neurological or psychiatric abnormalities. Important point here, ranging from subclinical alterations, and it can even lead to coma. So when we look at the incidence of hepatic encephalopathy, it develops in 50 to 70% of patients with cirrhosis. So quite a high number. So if the patient is of cirrhosis, again, we'll be seeing why exactly this happens. So if this occurs, if it happens, hepatic encephalopathy sets in the patient, it is a poor prognostic indicator. And again, the patient is definitely at very high risk. So with a projected, if we look at the 1 and 3 year survival rates, 42, and you see 1 year survival rate 42 and 3 year survival rate is 23. So rapid decline if the patient doesn't go for a liver transplantation. So the prevalence of overt hepatic encephalopathy. What exactly is the overt hepatic encephalopathy if we talk about? So overt encephalopathy is basically the clinically apparent neurological and psychiatric abnormalities. So the apparent, which is, the symptoms can be confusion, there can be disorientation, there can be asterexis, that is known as flapping tremors, somnolence, coma. So clinically apparent neurological and psychiatric abnormalities, which is caused due to liver dysfunction and ammonia buildup, is a OHE, that is a overt hepatic encephalopathy. So the prevalence at the time of diagnosis of cirrhosis, because it is present in 50 to 70% of the patients of cirrhosis, is 10 to 14%. So in decompensated cirrhosis, a bit more, 16 to 21, and after transjugular intra or portosystemic shunt, it is 10 to 15%. So the risk, if we see the first bout or the first episode of OHA, is 5 to 25% within 5 years of the diagnosis of cirrhosis. So 40% within 1 year after the index overt hepatic encephalopathy, and subjects with recurrent have a 40% cumulative risk of another recurrence. Very important point. 40% another recurrence within 6 months, despite you give lactulose treatment. So we'll be seeing why lactulose is been given in the treatment of hepatic encephalopathy. So when we talk about the pathophysiology of hepatic encephalopathy, there has been a number of factors that has been implicated, like production of neurotoxins, disruption of the blood-brain barrier, BBB, abnormal neurotransmission. So best described neurotoxin, if you have to say, if you call it as a Viva question or a one-word answer, the best described neurotoxin is ammonia. So once it is produced, it will enter the portal circulation, get metabolized, cleared by the hepatocytes. But again, if the patient has cirrhosis, portal hypertension, the functions of the hepatocytes, that is the functional cells of the liver, are being reduced. That leads to increased ammonia levels because it will not get metabolized, it will not get cleared by the hepatocytes. So over a period of time, it will get accumulated in the liver and will cause all the signs and symptoms. So this is the, overall, if we have to understand how exactly is the production of the ammonia, how exactly is the urea cycle that operates. So if you see in the urea cycle, carbon dioxide combines with ammonia through the acting of carbamoyl phosphate by the carbamoyl phosphate synthase, and ornithine carbamoyl transferase forms the citrulline. And then through the L-aspartate in the liver by the arginosuccinate synthase, it forms the arginosuccinate. From the arginosuccinate, with the help of arginosuccinate lyase, it forms L-arginine, and by the help of arginase, it forms L-ornithine. So this is the basic urea cycle. Urea get released from this L-arginine to L-ornithine conversion with the all addition of the ammonia. So urea, 75% of the urea which is being produced in the urea from the urea cycle is being excreted from the renal. So renal excretion of this urea is being there, and 25% goes to form ureases, and from NH3 goes to the portal circulation, and the 15% goes to the systemic circulation. So if you see what happens when there is in the stomach, in the colon, amino acids from the glutaminase gets oxidized to form NH4 plus, and with the help of urease it forms urea in the colon. But again, if this cycle is being disrupted, if you see especially in the liver cells where when there is periportal hepatocytes, so what happens, the formation of from the ammonia from the portal circulation goes to form urea, and then again it enters into the hepatic venous system. So ammonia, from the ammonia forms the glutamate, glutamate forms the glutamine, and glutamine, this being released into the hepatic venous system through the portal circulation. So this is the overall pathway of metabolism, excretion of the various things. Now coming to the basic, if you have to understand how exactly is the pathophysiology. So if again astrocytes, when we talk about the ammonia and the brain cells, so astrocytes are the only cells in the brain. Very important, and it has been asked over and over period of time. If you'll go for any of the entrance examination or any of the viva, which cells in the brain can metabolize ammonia? So astrocytes. So alpha ketoglutarate acid through the NH3 gets converted to glutaminic acid. From the NH3 it forms glutamine. So glutamine accumulation, if it is being there in the brain, it leads to swelling of these cells, that is known as astrocytes, and it leads to ammonia. So when there is marked elevation of ammonia, it leads to more glutamate, thereby leading to more astrocyte swelling, more brain edema, leading to excitatory changes in the brain, leading to agitation, confusion, seizures, and coma. So glutamine is the osmolyte, so that it causes the cerebral edema and increased intracranial tension. So once there is a diseased liver, it cannot convert ammonia to urea, which we have seen it. So ammonia accumulates in the blood. Because of that accumulation of the ammonia, let's see this, because of this accumulation of the ammonia, it crosses the blood-brain barrier. Because increased permeability of the blood-brain barrier increases the uptake and excretion of ammonia by the cerebellum and basal ganglia. So once it crosses the blood-brain barrier in astrocytes, in the cells of the brain, this ammonia which has crossed the blood-brain barrier, it combines with the glutamate to form glutamine. Glutamine increases the osmotic pressure, thereby leading to astrocyte swelling, cerebral edema, and neurological dysfunction. So swollen astrocytes which are being there, which is known as Alzheimer's type 2 astrocytes, they can also impair, I'm so sorry, they can also impair the neurotransmitter regulation. And yes, they can also impair the neurotransmitter regulation, and they can also lead to impairing of the cerebral energy metabolism. So all these things, increased glutamine will lead to confusion, altered consciousness. There is also a neurotransmitter imbalance. What happens? There is increase of the GABAergic tone, which is the inhibitory neurotransmitter. So due to accumulation of the GABA, there is, decreased glutamate signaling that results in slowing of the brain activity, lethargy, coma, and resulting in severe hepatic encephalopathy. So because of this, there is lot of inflammation, infections, sepsis infections, systemic inflammation sets in, increases the blood-brain barrier permeability. A lot of inflammatory cytokines, tumor necrosis factor, IL-6 also worsen the ammonia neurotoxicity, which leads to a synergistic effect. Over a period of time, if you will see, there is also manganese deposition which occurs. So manganese deposition occurs in a chronic liver disease, that is the CLD, due to impaired biliary excretion. And these manganese deposition is present in the basal ganglia, and which also causes the movement disorders. When we talk about the portosystemic shunting, blood generally bypasses the liver, either naturally or due to TIPS surgery if it is being done. So because of more ammonia, more toxins that resist the systemic circulation, it goes to the brain. So this is the overall pathophysiology of the hepatic encephalopathy. When we talk about the clinical presentation, it produces a wide range of non-specific neurological and psychiatric manifestations. So when there is a lowest expression, it alters the psychometric test oriented towards attention, working memory, psychomotor speed, visuospatial ability. As it progresses, the patient can experience apathy, irritability, disseminations, may be reported by the relatives of the patients, and obvious changes in the alterations in the consciousness, motor function can occur. Disturbance of the sleep-wake cycle, excessive daytime sleepiness. Patients can develop disorientation to the time, place, person. Again, confusion, inappropriate behavior, agitation, stupor, and finally coma. So the International Society of Hepatic Encephalopathy and Nitrogen Metabolism, that is the ISHN, consensus use the onset of disorientation or asterexis as the onset of overt hepatic encephalopathy. So this is the now coming to the very important, asterexis over a period of time. This will be asked how asterexis happens, how asterexis, and you will be asked to elicitate it. If you see this, if you can see this video, this is the classical representation of the asterexis which is being shown in the patient. So it is usually often present in the early to middle stage hepatic encephalopathy. Very important point here to notice: it precedes stupor or coma. It precedes it. I'm so sorry for the revealing of the face. I'm so sorry. But it is present in the early and middle stages that precede. It is present before. So it is actually not a tremor, but the name given as flapping tremor. And what exactly it is a negative myoclonus consisting of loss of postural tone which is being there. So easily elicited by the actions that require postural tone. You can see the hyperextension of the wrists with separated fingers and rhythmic squeezing of the examiner's fingers, and you can see the flapping of the hand or movement is being classically seen in the patient. So this is flapping tremor or asterexis. So why exactly this asterexis occurs? It is the imbalance between the agonist and the antagonist muscle due to disturbed diencephalic motor centers. So detection areas is not only the upper and lower extremities, you can also see in the tongue. That will also see, you can see the rhythmic movement in the tongue. It is not specific to liver. Very important point to note. Many of the, even the clinicians make this mistake that, okay, if the flapping tremor is present, it is a hepatic encephalopathy. It can be present in uremia, it can be present in organ failure, stroke of brain, basal ganglia, carbon dioxide intoxication. So it is not specific and not seen in the advanced cases. So that's why it precedes stupor and coma. So when we talk about the symptoms, altered mental status, memory loss, disorientation, personality changes, memory impairment, slurred speech, confusion, coma, what exactly is the cause? And it is an important table. You can keep a note of it. The cause is cerebral edema, which we discussed in the pathophysiology. There can be GABA toxic effects, disturb of the GABAergic tone, inflammation, alteration in the blood-brain barrier, altered communication between the astrocytes neuron, and oxidative stress caused by the ammonia accumulation. Transient focal neurological deficits or seizure, again GABA toxic effect, cerebral edema, alterations in the cerebral blood flux. Asterexis, abnormal disturbed diencephalic motor centers. Why? That regulate the tone of the agonist and antagonist measures, and these are normally involved in maintaining the posture. So because of their disturbed dysregulation of this center, diencephalic motor centers, there is disturbed tone of the agonist and antagonist muscles. So Adam and Foley first describes asterexis in 1949. Presents in early and middle stage, not in late, not pathognomic. We have discussed CO2 accumulation, uremia, renal failure, basal ganglia, does not occur in advance, never seen in coma, very important. And testing for asterexis, again, which we have seen how to perform. Hyperventilation associated with acidotic pH, again. So compensatory mechanism that decreases the entrance of ammonia to the brain. So the patient can also hyperventilation. Hepatic dementia, again, associated with neuronal loss, can be seen in chronic hepatic encephalopathy. Manifestation, the patient can present with attention deficits, visiopractic abnormalities, dysarthria, difficulty in writing, apraxia, difficulty in speech, seen rarely, is reversible after either the liver transplant or TIPS procedure. Hepatic Parkinsonism, Associated demyelination of the pyramidal tract, again seen in chronic hepatic encephalopathy, resembles Parkinsonism disease. Hepatic myelopathy, again chronic hepatic encephalopathy. Only a few patients have sensory symptoms, does not respond to the standard therapy. So these are the, again, various symptoms. Hyperreflexia, hypertonia, pyramidal involvement, Parkinsonism symptoms like bradykinesia, tremors, which we have discussed, deposition of the manganese. So manganese, what it causes the changes in the astrocytes that promote the formation of type 2 astrocytes known as Alzheimer type 2 astrocytes. So it also acts as a neurotoxin. Tics and chorea are rare, and again severe Parkinson's seen only in chronic hepatic encephalopathy. Sleep latency, disturbance of the sleep-wake cycle can also be seen because of the ammonia levels. Fetor hepaticus, again attributed to dimethyl sulfide, can be found in cirrhotics with or without hepatic encephalopathy. So can be identified by the breath, smell of the breath, and serum of the patients with cirrhosis. So these are the symptoms which we have talked about. All of the chart, if we talk about, are the important various clinical signs and symptoms, and what exactly are the causes of these symptoms it is being associated. Now, when we talk about the classification of hepatic encephalopathy, it is being basically divided into three classifications. The first is according to the underlying disease. According to the underlying disease, it is being classified as type A, B, and C. A from acute liver failure, B from portosystemic bypass or shunting, and C from cirrhosis. When we talk about the time course, according to the classification by the time course, three types again: episodic, recurrent, that occur with a time interval of 6 months or less, and persistent, denotes changes in the behavior that always presents and interspersed with relapses of overt hepatic encephalopathy. So hepatic encephalopathy that is associated with acute liver failure, it is a type A. Patients with portosystemic bypass and no hepatocellular disease, type B, associated with cirrhosis, portal hypertension, or portosystemic shunts, type C, further subdivided into episodic, further subdivided into precipitated, spontaneous, and recurrent, persistent, mild, severe, treatment dependent, and you have a minimal. So these are the nomenclature, updated nomenclature, subclassification of hepatic encephalopathy. The third type, according to the precipitating factors, non-precipitated and the precipitated. So when we talk about the precipitating factors for overt hepatic encephalopathy by the decreasing order of their frequency. So when we talk about the episodic, you have infections, GI bleed, overuse of diuretics, electrolyte disorder, constipation. When we talk about the recurrent, electrolyte disorder, infections, constipation, again, overuse of diuretics, and GI bleeding can be the cause. When we talk about the diagnostic criteria of hepatic encephalopathy, you have the very important West Haven criteria, which is being there. So it is being subdivided, or it is being divided on the basis of stages, stage 0, 1, 2, 3, 4. And again, on the basis of consciousness, intellect and behavior, and neurological findings. So this is the very important West Haven criteria when you have to classify, or when you have to classify according to the various stages in which the patient is present. So stage 0 is a normal. Consciousness is normal, the behavior of the patient is normal, and there is a normal neurological findings. If impaired, again, you can do a psychomotor testing also. When we talk about the first stage, there is mild lack of awareness, shortened attention span, and mild hysterexis or tremor can be the neurological finding. Stage 2, the patient can appear a bit of, dull, lethargy, disoriented, inappropriate behavior can be present. And along with these, there can be slurred speech, which is being present. The third stage is the somnolent but arousable. Gross distension, bizarre behavior, muscular rigidity, and clonus and hyperreflexia. The fourth is the final stage is the coma. then there is neurological findings you can get is of a decerebrate posturing. So this is the famous West Haven criteria. Now a newly diagnosed, criteria, West Haven has also been updated in the recent 4 or 5 years. So it has been classified as the normal impaired and progresses to the grade 4. So normal unimpaired, grade 0 to 1, grade 2, 3 and 4. So increased cognitive dysfunction and reduced level of consciousness as the grade progresses. And grade 2, 3, 4 is the overt hepatic encephalopathy with prominent neurological and psychiatric disturbances. So normal unimpaired, no sign symptoms. Grade 0 to 1, no sign symptoms, non-specific changes. Grade 2 can have a confusion, asterexis. Grade 3, obtundation, responsive to noxious stimuli. And a grade 4 is a coma. So this cognitive dysfunctions worsens, or there is a dysfunction which is being increased as the grade progresses. So this is the newly designed or the newly laid West Haven criteria according to the previous. There is one more criteria which has been given according to the severity. So according to the severity by the Ishan criteria, so unimpaired, again no hepatic encephalopathy, minimal psychometric or neuropsychological alterations exploring the psychomotor speed, abnormal results are being seen. Grade 1, trivial lack of awareness, there can be anxiety in the patients, shortened attention span, impairment of addition or subtraction, and altered sleep metabolism can be there. Suggestive operative criteria, if we talk about, despite oriented to time place, the patient appears to have some cognitive and behavioral decay. Clinical findings usually not reproducible. So this is the episodic according to the grade West Haven criteria, which is present according to the days and months. So clinical detection level, persistent. Again, there can be areas of fall and rise, and minimal hepatic encephalopathy below the level of clinical detection level, which is being present according to the grade of West Haven criteria as the days and month progression, which is being there. Further, grade 2, the patient can be lethargy, apathy can be there, clinical findings can be variable. Grade 3, again, somnolence, semi-stupor, the patient can be confused, bizarre behavior. And grade 4 is a coma, does not respond to even a painful stimuli, comatose state, which is usually reproducible. So according to the New American Association for Study of Liver Diseases, they have also classified the, hepatic encephalopathy on the basis of A, B, C. So A is acute liver failure, B, portosystemic bypass, and C is cirrhosis. So in A, you have a grade 1 that is also falling in the B group. So B also has 1 and 2. So A, the time course here is important. 1 episode in 6 months. No precipitating factor found. B is a overt, recurrent, greater than 1 episodes in 6 months, and C is a cirrhosis, that is the 3rd and 4th, persistent, never return to the baseline, which we have seen in this. So never returned is the, I'm so sorry, grade C, which is the type C, which is being there. Yes. So any doubt as of now? I hope I'm very clear. We have discussed the definitions. We have discussed the type of hepatic encephalopathy. We have seen the clinical presentation. We have seen the pathophysiology, and now we'll be progressing again to see again some more points. Any doubt as of now as we progress ahead with these sessions? I think I'm very clear up till now. All the 4 stages we have covered. The pathophysiology has to be, very clear. It has to be understood, and especially the, the Y asterexis. These are the very common mistakes that you see that, asterexis is typically linked or typically related to hepatic encephalopathy. It is not so. Okay, thank you so much. If we are clear, we are going ahead now. If we look at the grades of encephalopathy, which we have seen before, all the grades and all the classification, a grade 0 is a normal, no abnormality, intellectual function is normal, personality, behavior of the person is normal, neuromuscular abnormalities, there is no neuromuscular abnormality. So as the grade progresses, the impairment also progresses. So grade 1 is a mild. The patient can have hypersomnia, more sleep, insomnia, less sleep, inversion of the disturbance of the sleep-wake cycle. Shortened attention span when we talk about the intellectual function, exaggerated of the normal behavior. The patient can have euphoria, depression, irritability can be present when talking about the personality and behavior. And when we talk about the neuromuscular abnormalities, the patient can have incoordination, impaired handwriting, metabolic tremors can be there. Grade 2, progressing from disturbed sleep-wake cycle to lethargy, slow response, loss of time of place person, again more impaired computations, amnesia for the post events, patient starts forgetting, intellectual function, personality behavior, overt change in the personality, anxiety, inappropriate behavior, apathy can be there. Neuromuscular abnormality, so you see asterexis, grade 2, slurred speech, ataxia, hypoactive reflexes can have hyperactive also, but more in the 3, but again seen in the grade 2 also. Grade 3 is a severe impairment, somnolence, confusion, semi-stupor, minimal disorientation, loss of place, time, person, amnesia. When we talk about the personality behavior, the patient is more rage, aggressive behavior, anger, bizarre behavior can be there, nystagmus, abnormal movement of the eyeball, Babinski sign, rigidity, hyperactive reflexes. And the last stage, again, coma. So from stupor goes to the unconscious state, loss of self because the patient is in coma, no intellect, personality behavior, of course, coma, none. Neuromuscular abnormalities, there can be dilated pupil of tonus. So this is the important chart based on the grades of encephalopathy. You see the state of consciousness, intellectual function, personality behavior, and neuromuscular abnormalities. Again, an important chart. So this we have again type A, B, and C, which we have already discussed, episodic. Type A, B is recurrent and C is persistent. So if we talk about, for example, if you see the recommended description of a patient with hepatic encephalopathy, the patient has hepatic encephalopathy in a grade of type C, grade 3, recurrent, precipitated by the urinary tract infection. So this is exactly the pro forma how you will describe a patient of a hepatic encephalopathy, just for your reference, just for the example. So in grade 3, type C, because it is a type C, grade 3 and 4, recurrent, time course, precipitated, and it is being precipitated by what? By the urinary tract infection. Okay. Which slide, Twinkle, you have not understand? Which slide? The previous slide? This slide? This is a very not much difficult slide to, understand, because it is based on the grades of encephalopathy. Based on the grades of encephalopathy, the state of consciousness, intellectual behavior, as we have discussed, why there is a change in the intellectual function. There is a, the patient's behavior is changed. The overall neuromuscular abnormalities set in based on the grade. So as grades progresses, you see there is a grade 0 is a normal grade. It should be very clear in mind. It is a normal grade. And as the grade progresses, more and more impairment sets in. The patient starts to get more worse. And with all these signs, which starts from disturbance in sleep-wake cycle or with a slight of impaired consciousness, it gets more and more disoriented as the grade progresses. So there is some disorientation. The patient is mildly irritable in maybe if it is he or she is in a grade of 1+, but over a period of time, he will get more aggressive, more paranoid, anger, rage, and again, grade 4 is a coma. So this is the period, or this is the transition from mild to severe, or maybe from mild to worse stages, with every change in the personality, intellectual function, and neuromuscular abnormalities. So when we talk about the differential diagnosis of overt hepatic encephalopathy, there can be a diabetic, alcohol, intoxication, drugs, benzodiazepines, neuroepileptics, neuroinfections can be there, psychiatric disorders, electrolyte disorders like hyponatremia, hypercalcemia, non-convulsive epilepsy, intracranial bleed and stroke, and severe medical stress. Other presentations like, obstructive sleep apnea because of the hyperventilation, or maybe the patient is getting dull, drowsy, brain lesions and dementia can be the add-on differential. So you have to form a differential diagnosis picture. Once you start ruling out your differential diagnosis, you will ultimately come to the final diagnosis. Now coming to the diagnostic part of it, how you will diagnose a patient of hepatic encephalopathy. So hepatic encephalopathy, the first is the portosystemic encephalopathy syndrome test. So this test battery consists of 5 paper pencil tests that evaluate the cognitive and psychomotor processing speed and visuomotor coordination. So easy to administer and have a good external validity. I think we'll be seeing this. Yes. So various kinds of test is being performed. Continuous reaction time relies on the repeated registration of the motor reaction time to auditory stimuli. Paper and pencil psychomotoric tests. So validated for hepatic encephalopathy, but again on the basis of a lot of it has 96% sensitivity and 100% specificity. So you give a paper and pencil to the patient, and it has a if less than -4 is diagnostic, and less than -6 is of poor prognosis. So pencil and paper psychometric test for diagnosing the hepatic encephalopathy. So if not available, then abnormalities in 2 of the tests, at least, like number connection test, digital symbol test, serial dotting, block design test can be there. So intelligent cognition, there can be a lot of tests which is being there. And when we talk about the various psychomotoric tests, like intelligence and cognitive tests, there is mini mental state examination, personality factor test, MMPI test which is being there, projective test is being there, like completion test, sentence completion test. So the patient is not able to complete sentence, you will give the dot to the patient and you will ask him to circle the dots based on the number, and you will do the line tracing. So you will tell the patient to trace the line based on the line which is being provided, just like a game which we have played in our mobile or so. Serial dotting, so the patient is given these dots and the patient is asked being to map these all dots which is being there. Digital symbol test, so based on the symbol, you give a symbol of this and you will tell the patient to mark the digit or tick the digit based on this. So if you will give a symbol of V, the patient is asked to write here based on the digit. So V has to be written on the 1. So these are the normal scores, like digit symbol test, line tracing test, serial dotting test, line tracing. So these are the various psychometric tests which is being done to test the patient of hepatic encephalopathy. Repeated battery for the assessment of neuropsychological status. So RBANS is, again, when we talk about, has been used for the evaluation of Alzheimer's, schizophrenia, and traumatic brain injury. It has not been specifically validated for hepatic encephalopathy. So it helps to test attention, psychomotor speed, visual motor coordination of the patient, and executive functions. So again, a patient of this RBNS test, the component of RBNS test which is being given, which has been done, has been given, hepatic encephalopathy patients predominantly perform worse in the subcortical components. So the whole and soul of the test, this RBANS test, is to assess the global cognitive status, subtle changes in the cognition of the patient, and response to the treatment of cognitive disorders. So immediate memory, visuo-spatial memory, and language is being tested. But again, the applicability of this test is limited because it is administered and scored by the psychologist and specifically by the psychiatrist. So again, over a period of time, in many of your centers, you won't have access to these kind of tests which is being there. Neuropsychological test, again, performed under the supervision of neurologist only. You have electroencephalogram, visual evoked potentials, brainstem auditory evoked potentials like BERA. So critical flicker frequency, various kinds of tests. But again, EEG and visual evoked potentials have not been shown to provide diagnostic information which is being critical for the diagnosis of chronic hepatic encephalopathy. Very important point to know. Another test is a critical flicker frequency. So You don't need a psychologist, it can be performed in a short period of time. What exactly happens in hepatic encephalopathy? The retinal cells like astrocytes, as we discussed, they undergo edema. So light from 60 hertz and gradually decreasing till flickering. They are being subjected to press a button as soon as the impression of fused light switches to the flickering light. So it has been given in a threshold of 38 to 39, and once the patient training is being done, the mean value is being calculated. So there is a pulsating light emitting diode which is being given, and this hepatome which you can see consists of a hand control. There is a headset which is being placed. There is a patient stop button. So the patient or the light given in a hertz frequency of 60 hertz gradually decreasing till it is being frequency, and the patient is asked to press a button as he sees the impression of a fused light switches to a flickering light. So fused till the flickering, the patient is asked to switch. But again, drawbacks, it is not until validated in the USA. It requires a vision again, and fogging of the glasses can be there because you need a glass to be applied to the patients. Old age patients can have difficulty in performing this test, and the patients on any chronic medications can also have difficulty in performing this test. Another like Stroop smartphone application is being available, and again this is also app which is there on the iTunes Play Store. It measures the psychomotor speed, cognitive flexibility. It consists of identifying the colors of symbols, very important, and delineating the correct color of a color word that is a different color, that is red in a green colored front, and reaction times. So the patient is asked to identify the red color, sometimes in a green background or so. So a cutoff time of more than 190 seconds identified chronic hepatic encephalopathy. Overt hepatic encephalopathy patients do worse than those without. So it is correlated with accidents, illegal turns in driving stimulation test. You can see that you have to identify color symbols which is being given. So now this is the important chart, the diagnostic test, various diagnostic tests. What is the advantages and disadvantages? You can keep a note of it. So serum levels of ammonia, every time we see a patient of hepatic encephalopathy, we see the levels of ammonia. We tell the, every staff or we do that send the levels of serum ammonia. But why to send? What exactly is the importance? Whether it has a sensitivity or also or not, at the end of the day, many of the people don't know. So serum levels of ammonia positively correlated with the severity, but does not change approach to diagnose and manage. Can be challenging to take blood samples. West Haven criteria we have discussed. Hepatic encephalopathy scoring algorithm. Neuropsychometric test we have discussed again as the gold standard. Again, repeatable battery for the assessment of neurological symptoms. There is computerized psychometric test being there. Detects the hepatic encephalopathy with a high sensitivity which is being there. So critical flicker frequency we have discussed. Electroencephalography. Hepatic encephalopathy can present with a slow frequency of electrical activity in the electroencephalogram. Brain imaging techniques. The patient can be asked to go for MRI and CT. So MRI, multiple techniques. CT again useful for excluding the other causes of encephalopathy like any subdural hematoma or cerebrovascular events also. When we talk about the laboratory testing, high blood ammonia do not add any diagnostic staging or prognostic value in HE patients with chronic liver disease. Brain imaging, MRI, that is magnetic resonance spectroscopy. MRT1 mapping with partial inversion recovery, that is the TAPIR. They are used to measure the clinical parameters which are being present and the imaging modality which is being performed. So MRI technique, T1, proton spectroscopy, and T2 flare sequence diffusion weighted imaging which is being given. So imaging abnormality, what you can find when you do a T1 weighted imaging, you can see a bilateral symmetrical high intensity signal in the basal ganglia. When you do a T2, you can see a diffuse increase in white matter in the cerebral hemisphere and the corticospinal tract which is being there. Proton spectroscopy, increase in glutamate and glutamine signals, decrease in myoinositol and choline levels, which is being there. Clinical correlation can also be there. So changes resolves after the liver transplantation. You can see reverses after the liver transplantation. Latest guidelines. So hepatic encephalopathy should be treated as continuum ranging from unimpaired cognitive function with intact consciousness through coma. Diagnosis is through diagnosis of exclusion, when you exclude out the other causes of brain dysfunction. Should be divided into various stages. Overt hepatic encephalopathy is being diagnosed by the clinical criteria which we discussed according to the grades, according to the WHC and the GCS criteria. So diagnosis can be made using the various psychomotoric and neurophysiological tests. Tests could be used in patients who would most benefit, such as impaired quality of life. Very important. Increased blood ammonia, which we have already discussed, does not add any diagnostic or prognostic values in patients with CLD. So a normal value of serum ammonia doesn't rule out hepatic encephalopathy, and it calls for a diagnostic revaluation. Very important. When we talk about the treatment, very important, an episode of overt should be actively treated. Secondary prophylaxis after an episode is recommended. Primary prophylaxis for prevention of the episodes is generally not required until and unless the patient is the patient of cirrhosis having a high risk or tendency to develop hepatic encephalopathy. The indications of liver transplantation: recurrent intractable overt with a liver failure. So when we talk about the specific approach to overt hepatic encephalopathy treatment, we categorize it on the basis of four-pronged approach to the management. Initiation of the care of patients with altered consciousness. So if the patient is dull and drowsy, sometimes you have to put the patient on ventilator. You have to secure the airway. So ICU management, admit under the ICU, airway secure is a must. Either put the patient on BiPAP, CPAP therapy, and if there is a, maybe, the patient is completely dull, drowsy, the pH is getting deranged, maybe CO2 washout is being there, the patient has to be put on the ventilator also. Alternative causes of the altered mental status has to be ruled out. Identification of the precipitating factors, which we have discussed, has to be ruled out, and commencement of the empirical hepatic encephalopathy treatment. So rule out other causes: hypoxia, hypercapnia, uremia, which we have discussed, cerebral edema, hypoglycemia, very important, drug intoxication. While correct the metabolic part. Yes, sir. Yes, you are right. So identifying the precipitating cause, again, there can be a long list of precipitating cause from ranging from sepsis to uremia to, any CNS active drugs, development of HCC. And initial empirical treatment, very important, lactulose, we'll be seeing why lactulose is being given. Oral dose of 15 to 30 ml BD, rifaximin, gut antibiotic 550 BD, neomycin, again, oral dose 550 QID, metronidazole, antiparasitic, antihelminthic 250 QID, vancomycin, antibiotic 250 QID, sodium benzoate, oral dose 5 mg BD, and flumazil IV 1 to 3 mg, but vary for a short duration. So this is the empirical treatment which we will perform. So when we talk about treat the precipitating factor for the treatment, anemia, again, nutrition, very important, branch chain amino acid supplementation. Medical therapy, when we talk about, you give non-absorbable disaccharides, lactulose, lactylol, antibiotics, neomycin, paromycin, rifaximin, ammonia lowering agents like ammonia scavengers, polyethylene glycol, Lola, L-ornithine, L-aspartate. So it is a therapeutic agent. Why? Again, because it reduces the ammonia. L-ornithine, L-aspartate through the more enhancement of the urea cycle, which we have seen the urea cycle. L-ornithine, L-aspartate. So it converts the ammonia to the urea. Ornithine, phenyl acetate, sodium benzoate, sodium and glycerol, phenyl butyrate, and spherical carbon absorbent, which is being there. Some more medical therapy experimental has been tied with the use of probiotic, zinc supplementation, embolization of the portosystemic shunt if it is being there. Liver transplantation, artificial liver support can again be used as the modality of treatment. So treatment of the precipitating factor, if there is a GI bleed, because there is a bleeding, you need to replace the blood transfusion, correct the coagulopathy which is being there. Octreotide, proton pump inhibitors, endoscopic or angiographic therapy. If there is an underlying secondary or so infection, give the antibiotics. Sedating medications, if it is being given, discontinue it. Electrolyte abnormalities, maybe due to diuretics, discontinue it. Perform serial paracentesis. Constipation, the constipation has to be relieved. Renal failure, if it is being there, discontinue the diuretics, discontinue the renotoxic medications, and albumin administration because of the protein loss in renal failure. So this is the overall, pathway which is being there. Ammonia production through the systemic shunt. Astrocyte swelling goes to the brain. Inflammation, release of the inflammatory mediators, which is being there. And when you give all the antibiotics, rifaximin, probiotics, albumin supplementation, even Lola, zinc supplementation has been tried. Boil through the use of, lactulose, rifaximin, again, probiotics has been done. Neuromodulator, again, BZD antagonist like, Flumazil also. Now coming to the lactulose, these are the first line of therapy, lactulose and lactulol. Why it is being given? Increases the ammonia elimination. How? By decreasing the ammonia synthesis and absorption. So lactulose acts on the intestinal bacteria, converts to acetic and lactic acid, decreases the pH, decreases the synthesis, absorption of ammonia, increases movement of NH3 from the blood to the GIT. Very important. So increases colonic acetate, increases the H plus ions, converts the NH3 to the NH4, which is a non-absorbable form. And that's why lactulose is being recommended as the first line therapy. Promotes the growth of acid-resistant non-urease producing bacteria. Antibiotics, again, neomycin in a dose of 3 to 4 gram per day, inhibits intestine glutaminase, reduce ammonia production. You have to check for the ototoxicity because of the side effects of drug. Metronidazole, paramomycin, vancomycin, but again associated with bacterial resistance, and that's why MRSA and VRSA has to be dealt. Rifaximin, again, one of the very common drug and one of the common misused drug, I must say. Rifagut, any gut abnormality, start giving Rifagut. So rifaximin is, again, one of the most misused, and we are also going towards the increasing resistance of the rifaximin in some maybe couple of years or maybe down the line 5 to 10 years. So it is a NH3 lowering action, but again rifaximin monotherapy is unproven. So usually combined with lactulose. It acts against gram-positive, gram-negatives, acts in the small intestine, have a lowering bactericidal effect. 550 BD is the dose, can have adverse effect like headache, constipation, flatulence or so. But again, when we talk about it is equal to neopycin, but more NH3 lowering action, but with less side effects. But recent meta-analysis of the rifaximin has shown is as a equal or superior maybe to lactulose, but with less abdominal pain. So that's why a combo would be more preferable with the lactulose. Branch chain amino acids. So there is no effect of IV branch chain amino acids on the episodic bout. But again, L-ornithine, L-aspartate, we have discussed why it is being important. Metabolic ammonia scavengers like ornithine, phenyl acetate, glyceryl butyrate. So these agents, they through their metabolism acts as urea surrogates, leads to conversion of ammonia to urea, which is being excreted through the renal pathway. Glutaminase inhibitors, again, so the may be useful by reducing the amounts of ammonia which is being produced in the gut. When we talk about the nutrition intake, how much nutrition requirement is being there in a patient of hepatic encephalopathy. So daily energy intake or requirement is 35 to 40 kilocalorie per kg. Daily protein intake is 1.2 to 1.5 gram per kg per day. So small meals, liquid supplements has to be evenly distributed. Oral branch chain amino acids may be allowed, may be recommended to be achieved and maintained in patients who are intolerant of a dietary protein or so. Liver transplantation again is the last resort. So end stage, so liver transplantation resolves the both hepatic dysfunction and portal hypertension. it results in complete resolution. But again, graft rejection, donor, a lot of challenges is being there. So indication, recurrent or treatment resistant cases, MELD obstacle, end stage liver disease. So hepatic encephalopathy does not necessarily correlate with MELD score. So there is a complete MELD score which is used to calculate the end stage liver disease. Patients of hepatic encephalopathy may be disadvantaged in the era of MELD based organ allocation despite a serial impact of hepatic encephalopathy on the productivity, health and survival of the patient. So this was all about hepatic encephalopathy, right from the clinical presentation, pathophysiology, we discussed the investigations, we discussed the treatment modalities, right from why lactulose, why antibiotics, what are the role of supplementations or so. Okay, over to the any Q&As, and I think we have some MCQs also, maybe. You will, thank you so much. Okay, Siksha, thank you for the acknowledgement. And I think the slides will be definitely, I think you can coordinate with the team for, for this, having the slide share or so. I think the concept is, majority of the doubts, I'll tell you what exactly is thing that majority of the misconfusion, asterexis is completely linked to hepatic encephalopathy, not at all. Why lactulose is being given? I think we have already covered why lactulose is being given, why rifaximin is being given, why other antibiotics are being given, why, what is the role of liver in transplantation, when to give, when to not give, why hepatic encephalopathy occurs, what are the signs, symptoms, what is the role of brain cells, and how to test hepatic encephalopathy and asterexis and so. Thank you so much. Thank you. And I think I've covered all the, maybe again, if you have any doubts, I'm open to Q&As.
Yeah. Thank you, doctor. Meanwhile, I'll also drop Dr. Sunil, very good explanation and everything explained previously before asking. Thank you, sir. So,
Thank you. Thank you. Thank you, participants. And this is the whole and sole goal of our webinar is to, everyone has knowledge of this, every topics which we cover hepatic encephalopathy, but, clearing some basic doubts is something, why is this? We all know that asterexis is there. We all know lactulose is given. But again, why, what exactly is this, cause of it as something has to be talked about.
yeah. We also have dropped a link to attend the quiz. Please do attend the quiz.
Yeah, please do go through the quiz. It is a very interesting quiz, and this quiz is based on the session only which we have covered. So it is a very good quiz, and go through it. It will take you hardly few minutes.
Because meanwhile you ask questions, I also dropped certificate form. You can fill the form. You can ask questions. Doctor is here to answer your question.
Sir, good evening.
Yeah, good evening.
Sir, my question is, should we use AED in hepatic encephalopathy, anti-epileptic drugs? Hello.
Pardon? Can we have the question once again? Your voice just break.
Yeah, sir. My question is,
Yes, Dr. Manish, yes.
should we use anti-epileptic drug?
So
If patient is
generally, see, I've also discussed. If you go through the slides which will be shared, these are not routinely advised because they can aggravate or they can trigger. Because most of the anti-epileptic drugs, like you see, sodium valproate or maybe carbamazepine or phenytoin, they are hepatotoxic. So they can also lead to worsening of the liver toxicity. They can also lead to more altered mental status, and they can trigger also the hyperammonia. Some of the drugs, like so again, if it is being there until and unless a whole and sole indication is being there, like documented seizures, the patient is in status epilepticus or so, then you can go for the safe drugs like levacetriazam or so, like gabapentin or maybe pregabalin. But again, if the patient is settled, you have to stop the drugs, you have to treat this, and then you have to put the patient back on AED.
thank you very much, sir.
Thank you, Dr. Manish. Dr. Twinkle is asking, is its management same as we discussed in case AKT induced early with encephalopathy, sir? I'm
AKT,
sorry, sir.
anti-tubercular drugs you were talking about, anti-tubercular drugs. So again, those are hepatotoxic drugs. Again, if you can stop it, because if the patient is of a most of the hepatotoxic liver TB drugs has to be stopped for once the patient is in a hepatic encephalopathy stage or so. So you have to treat it. You have to hold this AKT for a period of time, because holding AKT for a period of time, the patient won't get hampered with the stopping of the AKT drugs for a period of time. So you have to stop this because there are hepatotoxic AKT drugs which are being there. So you have to stop it for a period of time. You have to treat, and then you can maybe restart the anti ATT drugs or anti AKT drugs which you're talking about. We have discussed this, the role of lactulose, Dr. Farooq. We have told it will lead to, more conversion of NH3 to NH4, and it will lead to washing out of the NH3 from the system, from the blood, and it will lead to conversion to the urea. And treatment we have already covered. Everything has been covered, Dr. Milan. We have covered in the PPT, treatment of hepatic encephalopathy. Manganese level you can do if you have, again, if you have a setup at your center for checking the levels of manganese, definitely go for it.
Doctors, you can also unmute yourself and discuss with the doctor. Dr. Priyanshi, please fill the certification form. The certificate will be sent to you by the next 3 working days. So please make sure you fill the form with the proper email ID and the name. We will send it to you. Thank you. Doctor, we have 2 questions. All alcoholics, should they undergo any testing in early stages?
The psychometric tests which we talked about, they can definitely be done. Ammonia levels, of course, if you are suspecting, if you have gone with the diagnostic modality, like if you have gone for the serum ammonia, if you have also gone for the CT or MRI, and if you are suspecting any river abnormality in that, so definitely they must undergo.
Doctor,
So, yes, I'll just go through it. So, you become restless, you can give a short-acting midazolam or lorazepam can be given again, maybe just to calm down his, restlessness or so.
One more question. What is the role of Neuralink nowadays for neuropsychiatric behavior issues?
This, I think you're talking about the neurotechnology. So this, there is a chip which records the signals from the brain, and I think it has been developed by the Elon Musk company or so. So this is basically a chip. It is being connected to the software, and it basically it helps in a lot of research is also been going on. But again, if you talk about in India, how much not being much, it is still being under trial or again being researched. But again, good modality when talking about the West paralysis, spinal cord abnormality, a patient of stroke, neurological diseases is being, tried with this. So there is a chip connected to the software which, detects the signals which is being recorded in the system.
Sir, my another question is there. The patient sometimes in CLD, some patient are too much irritable, and then they are fight on the bed. So when LFT is deranged, so should we use midazolam or not used?
You can give a short dose of it. You can definitely use if they are too much restless. If you have restricted them, if you have tied them to the, maybe a patient has to be even tied to his bed or even has to be restricted. So you can definitely give a short or stat dose just to, just to calm things down and just to calm his anxiety and restlessness. Even with a stat or short dose, nothing will happen.
So what should we prefer? Should prefer lorazepam, yeah, we can give midazolam also.
Lorazepam is mostly preferred, but again, midazolam both are both can be given. But again, lorazepam has if you see the overall comparison between the bioavailability and so lorazepam has a comparatively better role when talking in terms of midazolam.
Okay, sir.
Doctor, we are getting quiz entries, so I can tell you that Gulshan Kumar scored 14 out of 15.
Great,
Doctor,
great, congratulations, Gulshan.
yeah, and Dr. Navneet Yadav scored 13 out of 15.
Great, great, congratulations.
Dr. Gaurav Gupta scored 12 out of 15.
So that means my session has been fruitful. So you all have scored a good. That's the whole and soul motive of the MCQs, just so that you have a quick recap of what we have discussed.
Yes. So, Dr. Vijay Singh Chauhan, 10 out of 15. Dr. Vivek Badaf, 9 out of 15. Dr. Parmeshwari, 9 out of 15. Dr. Jitendra, 9 out of 15. Dr. Anu Gupta, 9 out of 15. Dr. Fazul, 8 out of 15. Dr.
Great,
M.A. Irfan, 8 out of 15. Dr. Qureshi Tasnim, 7 out of 15. Jyoti Balamiki, 7 out of 15. And we are still coming. Dr. Mohammad Irshad, 9 out of 15. Pawan Kumar Upadhyay, 8 out of 15. Dipendra Yadav, 8 out of 15. We are coming. We'll still. There are a few more to come, I guess, doctor. But now we have seen these are the results. Yeah, great. Uh, Excellent session. Thank you, Jai Singh. So, please do follow us on our social media to get more such webinars because we have lined up. Uh, we have a dozen of webinars lined up this month. I think you might have seen it in our social media channels. So we also have started ultrasound sonography webinars. Please do attend that. We already have completed 2 webinars in that series. The USG series have almost 14 sessions planned. So please do look out for all the details in our social media channels in our WhatsApp groups. I have dropped our social media channel links. Please do follow us on all the, Instagram, YouTube, LinkedIn, because all our sessions will be there in our YouTube for your references. You can watch it there. Great. Thank you, doctor. Thank you for this insightful session. I personally learned a great deal. I know this are very often, but today was really, I learned a great deal, and I am sure all doctors here would agree with me. And today, for a fact that we can see that in a quiz, so doctors are scoring almost 80% of the quizzes. So that would prove that you always make sure to teach us that way. On behalf of everyone, I extend a sincere gratitude to Dr. Ayush. Thank you, and thank you for all joining us today for this webinar and for this valuable webinar. If you have any further queries or anything, please reach out to us through available means. You're all available in the WhatsApp groups. You can message us, and we'll get it done. The certificates will be sent to you in next 3 working days. Thank you so much. Thank you, doctor.
Thank you. Thank you. Thanks to the entire team of Mediversal and thanks to all the students. Okay. Good night. Take care.
Nice, sir. So I'll be here 5 more minutes. If anyone wants to fill the form, I'll paste the certificate form again in the chat box. Please do fill the form. If anyone wants to attend the quiz, I'm dropping the link for quiz also. Please do go attend the quiz. That way you will know how much you have learned, and if you have any questions, you can always pose at us. We'll try to get answer from the doctor as as soon as possible. Or doctor, we have out of out scorer, Dr. V. Kranti Kumari has scored 15 out of 15. Okay, speaker is not here. Congratulations, Dr. Kranti Kumari. You have scored 15 out of 15. So meanwhile, I'm here. If anyone wants to talk about our webinars, how they are going, you can come to camera or switch on your camera or unmute yourself and you can talk to us. Yes, I can paste the link again. I have pasted the certificate link and I'm also pasting the webinar quiz link. Thank you, Dr. Kranti. Session was really enlightening and fruitful. Thank you so much. Engagement like this make us conduct more such webinars. Thank you so much. And we are coming up with a lot more webinars. Dr. Kranti, if you want to talk, you can talk. You can share your experience.
Yeah, good evening, sir.
Good evening, Dr. Kranti. Please tell me.
Yeah, actually, I was trying for enrolling for some of the courses from Mediversal.
Okay.
Accidentally, I got this link just 5 minutes before the starting of the session.
Okay, okay. Dr. Kranti, please
Yeah, please.
give us your details. We will reach out to you. I will message you in private section. Please send me your details so that I will have our person to call you
Okay.
and will help you with with next steps.
Sure, sir. Thank you very much for your support.
Yeah. You can share your experience attending our webinars. How you felt? How was the class?
Yeah, I've done already given the feedback, sir. I filled the feedback form.
Thank you, thank you, thank you.
Yeah, thank you.
Please send us your contact details. Dr.
Yeah,
Pandey.
sure.
I think that should be it. Thank you so much for joining, everyone. I will be closing the session now. You have the certificate form, you have the quiz form. You can reach out to us.
వస్తాయి